So, if third-party reimbursement is one of the main reasons for documentation, we better talk about third-party reimbursement a little bit. So, when we talk about third party, we're just talking about insurance, okay? Third party just means you have the patient, who's the first party, the clinician, who's the second party, and then you have a third party, this insurance company, who is going to potentially be the payer. Third-party reimbursement involves all insurance companies, any form of insurance. I know in intro you go through a couple different of the types of insurance and different types of plans, and we'll talk about that again in leadership in your senior year. But the thing that kind of sets the tone for most third-party reimbursement are the Centers for Medicaid and Medicare, or CMS. And this is the government branch of insurance, right? So Medicare is for retired individuals, and Medicaid is for low income. And so this is what the government says as insurance we're going to cover. And so oftentimes when they make decisions, the CMS makes decisions, other payers kind of use them as the standard. So if the government's not going to reimburse for this, why should we? And in some cases they do things above and beyond Medicare, because that's why you purchase additional insurance beyond Medicare or Medicaid, right? You're expected to get more out of it. But they definitely use CMS as kind of a model to establish their own guidelines. So with athletic training, a lot of times there's this thought process that athletic trainers don't bill for services. They don't get third-party reimbursement. And that's not actually true. Any licensed healthcare provider is able to bill for services. Now, the insurance company can decide whether you are considered a appropriate provider for that type of care. And unfortunately, in 2000, the year 2000, CMS came out with a statement and listed specifically 4 or 5 providers that they would reimburse in the allied health world. Okay, so physical therapists, occupational therapists, speech pathologists, and a couple others. Athletic trainers were not on that list. They did not see them as appropriate healthcare providers for their patient population. Again, for the most part, that was true, especially in 2000. Athletic training hadn't kind of expanded into its role in in clinics as much. And things like that. So yeah, we didn't see a whole lot of health or retired age individuals. But now we're in the situation where individuals are living longer, they're staying active longer, they're involved in athletic events longer, and especially on the Medicaid side of things, that could be anyone. That could be kids who are in high school and need coverage. So it doesn't really reflect what we do. But unfortunately, they've stuck with their decision. And the fallout of that was that other insurance companies then said, well, again, if the government isn't reimbursing for this, why should we? And so third-party reimbursement for athletic trainers dropped significantly. Most third-party reimbursement that occurs right now is actually through individual negotiations with insurance companies. So especially if you practice in an area that is really highly covered by one type of insurance. So an example being like the Mayo Health system. They've been able to negotiate down in the Rochester area some of the athletic trainers to be reimbursed for certain services. Wisconsin, some of the Wisconsin hospital systems have some really good third-party reimbursement. Actually, they talked a lot about it at our own Minnesota state meeting this past spring, and they talk about it at GLADA, our district meetings, of how they kind of set up this reimbursement model. And so that's the goal. That's where athletic trainers are going. Now, there's a lot of debate between if we want third-party reimbursement, does it work for everyone? Does it work only for some people? If you have third-party reimbursement, you're only going to get paid for what the insurance company deems appropriately. And so, especially in a healthcare setting like a collegiate setting, that dramatically changes the care potentially. Right now, the employer, the college, pays the salaries of the athletic trainers in a means to essentially say that they're going to provide a service for their patients, in this case, their varsity athletes. at no charge to the patient. And there, the college is taking a return on that of, well, that's going to keep insurance costs down, that keeps legal issues down, it's less likely to be sued because of improper care, and so they kind of write off the salary of the athletic trainer and of the equipment and so on, and say it's covered by the savings and costs elsewhere. Now, if we go to a third-party reimbursement model, that would dramatically change collegiate, because now who's to say that a college would be like, well, if you could be actually earning us money, why wouldn't you do that, right? So we'll pay a salary, but you also need to be, billing so much a month or a year or whatever it might be. And then that changed the dynamic. It changes also the type of treatment decisions you can potentially make. If you want to be reimbursed, you have to follow guidelines for reimbursement. So the fact that someone walks in and gets stim twice a day just to kind of get them through the football season, that's not reimbursable, because that's not seen as the best practice or what insurance companies are going to pay for, even though it helps our patients and we see it. And we have that freedom right now. We might not in a third-party reimbursement world. And so no one knows that if we really strongly pursue third-party reimbursement and get recognized by CMS, if that would only really affect people more in clinics and hospital settings, or if it would trickle into some of the more traditional settings. So it's an interesting kind of future thing to be watching. But in general, kind of going back to what is third-party reimbursement and how it's handled. So you receive reimbursement for the services rendered, but that requires documentation not only of what you did, but of the condition. So certain conditions will be allowed to have certain treatments or certain procedures tied to them, while others might not. So all of that gets kind of analyzed in order to look at the billing. The individual rendering the treatment, so the clinician, has to be state licensed in their area of practice, and the treatment provided must meet the patient's treatment goals. So again, based on the condition, what are those things that are found to be most helpful? Evidence-based practice plays a big role in this. The decision to provide the reimbursement of the claim is ultimately in the hands of the insurance provider. And it has to do with whatever contract the patient has signed with their insurance provider. Also, what type of negotiations your clinic or hospital or athletic training service department has negotiated with insurance companies as far as the reimbursement rates for various procedures and treatments and things like that. Third-party payers in negotiation with these clinics and hospitals determine the rate of reimbursement, kind of the amount paid, and that's usually what they call based on usual, customary, or reasonable systems. So it kind of looks across the entire country. What are other insurance companies reimbursing for these things? What's the highest, what's the lowest, what's kind of in the middle, and they kind of negotiate and start their negotiations there. Again, have to have documentation of the condition, so of the evaluation leading to the condition diagnosis, as well as then the services rendered. So like I said, evidence-based practice really becomes key. Insurance companies will require documentation and evidence that a treatment is beneficial in order to meet the goals of this patient. This especially becomes tricky when you start using new treatment protocols or new types of devices or modalities or new theories of therapeutic exercise. The burden then becomes on you and on your employer to prove that that is a viable option and good evidentiary support for that treatment to the insurance company. The insurance company is also going to want to see both patient and clinician-centered outcome measures. So again, looking at things like range of motion and strength and functional activity, but then also the patient-oriented outcomes. They'll want to see that the patient is responding positively in that kind of anticipated time. That's how it's going to be assumed that the treatment's working and that they'll continue to reimburse up to whatever their limits are. And if it's not, they're going to want to see how that's been rethought and reevaluated. And if you don't kind of rethink things through, good chance that you're going to get your reimbursement claim denied. So how is all this done? There had to be some way to standardize conditions and treatments so that money amounts could be put to those things. And so that's what we call coding. And we have two sets of codes. The first one is the International Classification of Diseases, or ICD. ICD gets updated every couple of years, and America is actually usually behind the rest of the world. So we just adopted ICD-10 like a year and a half ago. The rest of the world had been using it for 5 years already. They're probably already working on ICD-11, and we're going to still be behind on that. But the ICD codes are really about pathology. So that's how you distinguish a injury. So there would be a certain code for a lateral anterior talofibular ligament sprain, right? And then probably the grade, and there's modifiers that go with that. It's what we call the clinical modifications of the ICD codes. And these were created by the American Hospital Association, again, as a way to, not only for billing, but it helps for documentation of the type of injuries and illnesses you're seeing. If you're coding things in a really standardized manner and you're using electronic medical records, even if you were using paper and you had that number, you could really easily just search for that number and pull up all of the ankle sprains that you're treating that year. And so then you can start to really use that for quality analysis, for going to your employer and to the money, right? And saying, hey, we're seeing all of this, we should get more equipment for this, or we need another individual. It just makes organizing the type of patients and the type of injuries that you see much easier. So again, every type of pathology would have some sort of code and potentially a modifier. So there's a number with a decimal and then the modifier after it. The current procedural terminology, which comes from the American Medical Association's Department of Coding and Nomenclature, and there's a whole department in the AMA for that, the CPT codes are really about treatments and procedures. So for the most part, when they're describing their treatments, they do not refer to a specific therapist. So they use the generic term therapist to mean any clinician that would be performing those services. There are a couple codes that are therapist specific. So like there is a code for athletic training evaluation and athletic training reevaluation that are specifically for athletic trainers to use. Same with physical therapy, and each provider has those. But the treatments, okay, so not the evaluations and the reevaluations, but the treatments tend to just be generic. Okay, and as long as you as a provider have the legal right to perform those skills, right, based on your scope of practice, you're able to bill for those services. And again, if you've negotiated with insurance companies that you're a provider that is allowed to do that. Modalities typically fall under the CPT physical medicine codes. So the CPT manual is massive, as you can imagine. If you're trying to do every type of treatment, and this is procedures too, so like surgical procedures, stitches, anything that could happen in a medical world is under CPT codes. So it's huge. So there's a section on physical medicine codes, and that's where typically modalities show up. And they're usually based on 15-minute treatment times, with the unit kind of rounded up or down at the halfway point. So if you do a 8-minute treatment, you get to round up to 15 minutes. If you're at a 22-minute treatment, you know, you're kind of right on that border, but technically down to a 15-minute treatment. Cold and heat packs are usually not eligible for reimbursement unless they're in conjunction with another procedure. So I always think back to when I was in high school and I had some knee issues and I went to physical therapy and they had me sit there in ice for 20 minutes on their table, and they billed for that because I had also done biofeedback and done exercises, and they were able to bill for that. And I'm like, that is just ridiculous. Like, I paid more than what an ice bag would take, and I could have done it at home. So now that's always my recommendation to people. Like, if you're going to go to physical therapy and they tell you they want you to ice after your treatment or after your exercise, you just say, I can do that on my own. And you'll save yourself and your insurance company a couple bucks. Another kind of weird example of CPTs is that phonophoresis is not actually a CPT code. Okay. It's not eligible as a code. Ultrasound is. So most people put phonophoresis under ultrasound, and then there's usually another procedure code for application of medication, topical application of medication. So they combine those two to create phonophoresis. Or they list it under what's called an unlisted modality, which is a 97039 code. And that's much more likely to be denied. You're going to get questioned about that and what that is. So there are some interesting kind of quirks in the system, if you will. In your textbook, box 4-4 has some typical codes that would be used for modalities, and you can take a look at that. Also up on Moodle are some resources for different codes, because as a senior especially, you'll have to do coding for your CIPs. So for your treatments and evaluations and what you've done, you'll have to kind of put the codes that would relate to those in your CIPs.